In 2016, a 28-year-old mother arrived at a community health center in rural India. 40 weeks pregnant and bleeding severely, she was clearly in distress. The birth attendants at the center recognized that she needed emergency care. She had to get to the district hospital quickly. Around the world, maternal hemorrhage is one of the leading causes of death in childbirth. The nurses prepared her referral, a routine practice that relies on a rapid response system of communication, transportation, teamwork, staffing, and supplies. What happened over the next 2 days with this mother reveals what it will take to stop the preventable deaths of women and newborns in childbirth.
I'm Catherine Semra, and for the last 4 years, I have led one of the largest studies ever conducted on maternal neonatal mortality and childbirth care. For 2 years, we tracked childbirths across 120 facilities in one of the largest and poorest states of India. Uttar Pradesh has some of the highest rates of death in childbirth in the country, and the experiences reflect what is happening in many parts of the world. We wanted to see if we could reduce the deaths of women and newborns by coaching birth attendants to use the WHO Safe Childbirth Checklist. The checklist's 28 clinical practices are known to save lives. With the checklist and coaching, birth attendants succeeded in providing significantly better care for women and their newborns. That is good news. The progress in Uttar Pradesh shows us that it is possible to improve the quality of care even where resources are limited. But those improvements were not enough to save lives. We wanted to know why. We need a deeper understanding of what is happening at the front line of care. The BetterBirth study offers unprecedented insight into real-world, specific, measurable health system gaps and failures that contribute to high rates of maternal and neonatal mortality around the world. The answer is not what we thought it would be. In fact, the problem is bigger than any one factor in any given facility, and it's a global challenge. The problem and the solution lies in an idea called systemness. Systems are made up of various components. Think of systemness as the glue that holds everything together. When there is systemness, there is seamless integration and cohesion of the various parts of the health system. Women receive better care and have a more positive experience in childbirth. In the BetterBirth study, we learned that systemness, or lack of it, makes the difference between life and death, especially when it comes to women with complications. As part of our study, we interviewed many families to understand systems of care surrounding childbirth. Our story is drawn from their recollections, and most importantly, it is a story that is repeated in settings around the world.
Birth attendants at the community health center appropriately referred the mother on to the district hospital. But the district hospital was busy that day, so the family decided to leave. The couple went on to a private hospital. By her next stop, she required a blood transfusion, a life-saving intervention that this hospital is designated to provide. But when they arrived, the blood bank was closed. They headed on to yet another private hospital in a different district. At this hospital, the mother received a blood transfusion, and by then, she also required a C-section. This facility should have been able to provide emergency obstetric care. Nurses tried to reach an OB/GYN, but could not track one down. With no doctor to perform a C-section, the mother was referred the next day to the tertiary hospital in the capital. She died in the ambulance on the way. The baby was never delivered.
At each stop along this mother's journey, the system broke down. Even when nurses were doing their best, there were barriers at every turn in communication, teamwork across facilities, staffing, and supply availability. This reflects what we heard consistently from the families of women who died in childbirth. Of the 149 women who died in the BetterBirth study, at least 82 women were referred out for higher level care, and at least 21 women died in transport. The breakdown of referral systems is a global problem. Fixing a maternal newborn health system can seem overwhelming, but there is tremendous opportunity to take action today in systems everywhere. First, women need proper prenatal care so risk factors are identified and managed, and women know where to go for childbirth. Additionally, frontline facilities need to be prepared to respond to emergencies. Birth attendants should be trained to identify complications, stabilize women, and correctly refer them in a respectful and reassuring way. Communication systems between referring and receiving facilities must function 24/7. Health providers should have functioning protocols for passing on critical patient information. Essential supplies like medications, blood, and equipment must be accessible at all times across the system. We need safe, reliable emergency transportation with trained drivers, medical personnel, and properly equipped ambulances. Higher level referral facilities must be at the ready to provide emergency obstetrical care. Achieving systemness will not be an easy task. There must be total buy-in from leaders and providers across the system, and this commitment must include birth attendants on the front line. We can start by looking at the referral system and strengthening each of the components needed to care for women who are most vulnerable in childbirth. When all of the components of the system are integrated and working seamlessly, we give women and newborns a fighting chance.